So I'll just say a few words about the lecture series and the speakers today first. So as you may know, this is a lecture series that has been going on for 10 years. Most of these lectures are on YouTube. Actually, these 2 lectures today will also go on YouTube. So if you have colleagues who couldn't make it, you can tell them where to find these lectures. It's actually there. We are approaching 500,000 views, so you might be the lucky one who gets this 500,000th view if you go there. The next lecture in this series will probably be in November. The final date isn't set yet. It's Audrey Turka who will speak about early life stress. And to get updated on when it's actually happening, go to Facebook or the Center for Psychiatry Research, psychiatriforskning.se webpage. And today is the first bilingual Stockholm Psychiatry lecture. So we have 2 distinguished speakers. The first one will be in English and the second one actually in Swedish. And it's also a kind of progression. So we will first hear about the science of suicide prevention. And then Peder Björling will actually tell us how to write a good crisis plan. I at least find myself struggling sometimes to make it a bit more less standardized. So our first speaker is Dr. Barbara Stanley, and we are really honored to have her here. She's a very well-known expert in suicide prevention and suicide research, also in personality disorders. She's a professor of medical psychology at the Department of Psychiatry at Columbia University in New York. And she's also the director of suicide prevention training at the Center for Practice Innovations at New York State Psychiatry Institute. And she has, as you can see on this slide and probably elsewhere, she has a long list of big grants in this area and important publications. So please help me welcome Dr. Barbara Stanley.
So I was going to say something about how honored I was to be invited to this incredible institution and to speak here today and among this prestigious audience. However, I understand from having read my guidebooks that we don't complement each other in Sweden, and so I won't say any of that. The other thing that I learned, I go to Norway twice a year, and I learned this in Norway too, but this is from my guidebook in my hotel room that says, so I promise that I won't do this, do not make human contact with Swedes, such as small talk. In other words, mind your own business. So I will try very hard to mind my own business. So usually the only people that I end up chatting with are the taxi cab drivers, and they indulge me. But being from New York, we are very big on chit-chat. So today I am going to speak about whether a crisis intervention can prevent suicide. And I'm going to be talking mostly about the intervention that my colleague Greg Brown and I developed, and that's being used throughout the United States and in many other countries. So these are my disclosures, just so that you know where my funding comes from. So this is one of my favorite books, and this is by Malcolm Gladwell, and I love the subtitle, How Little Things Can Make a Big Difference. And so I like to cook, and so this is a chili pepper, and again, here is a little thing that can make a big difference. If you chop up a chili pepper and put it in a recipe, it's very different than without the chili pepper. And so brief interventions like the safety planning intervention are little things that can make a big difference. And I'll show you a little bit of data on that today. So I'm not going to spend a lot of time talking about statistics, but I just kind of want to put it in context for you. This is a figure that, that we all know about. About 800,000 people die by suicide every year, which means that there's one suicide every second, so almost 2 per minute. And a lot of the suicides come from low and middle income countries, and it accounts for almost 1.5% of all deaths worldwide. And in young people, it's the second leading cause of death. Of course, there are many, many more suicide attempts than there are suicides. We actually don't have a good idea about how many suicide attempts there are because many suicide attempts never come to the attention of medical professionals. And in fact, even, we were just talking about this at lunch, even for people who are in treatment, they may have had a suicide attempt that they don't reveal to their clinician ever. And so sometimes it's a very private thing. But we do know that suicide attempts and self-harm generally are predictors of later suicide. So this just gives you an idea about the rate of suicide across the world, and you could see that it looks like the rate in the United States is about the same as the rate in Sweden, but it actually is a very, very different picture when you look at trends. In Sweden, this is the suicide rate over several years. And it's very, very different than in the United States. So it's kind of stable. It goes up a little, goes down a little, goes up a little, goes down a little. This is what it looks like in the United States. So these are the leading causes of death in the US. And so we have heart disease and cancer here. So this is over 15 years, and this has continued. I have up to 2015. It's been continuing in the same direction. And so the leading causes of death are all going down in the United States. In contrast, the suicide rate is going up. And so we look different than many of the other countries, and it's unclear why. So we've been devoting a lot of effort to figuring out how we can do better at preventing suicide. So this is what I call the suicide prevention wheel. So I'm going to be focusing here, but I just want to make sure that we keep in context here all the other things that we need to do to prevent suicide. So I'm going to focus here, but when I get these questions about, well, can safety planning prevent suicide? It's like, okay, that's a reasonable question, but I would never, if I were working with a person who was suicidal, I would never just do safety planning. I would do a whole bunch of other things with that person besides safety planning. And so I think we shouldn't ask too much of any one intervention, and we should be thinking about doing all of these things. So they're population-based interventions, screening, we have to do identification, there's emergency and respite care and the hotline. So these are all kind of more population-based. These are the things that we do, the screening and the identification and the risk assessment before they can even get to here. And then, of course, there's psychiatric hospitalization. We've developed suicide-specific pharmacotherapy and brain stimulation now, suicide-specific psychotherapy. So all of these things fit in the context. So I am going to turn to talking about this, but I think it's really important to remember that it fits in with everything else. So what does a brief intervention do? If it's for suicide prevention, it's to reduce imminent risk, and I really focus on imminent risk, to enhance help seeking, and then to provide a safety net for people between an emergency visit and then any kind of follow-up care. So what are characteristics of brief interventions? They're a tool for use when contact is limited. It can be a single session or several sessions. The goal is limited and specific. So it's a specific goal. It's not doing several things. What are the desired outcomes that we have for brief interventions? It's psychoed, so it's teaching people, for example, about what are their personal risk factors for suicide. It's getting some insight change or increasing motivation, skill building, which is kind of where safety planning falls in line, and then knowledge acquisition. And it can include outreach and follow-up, so like phone calls, letters, texts. The important thing to remember, and this happens a lot now with safety planning, is that this is not a piece of paper or form to fill out. This is a therapeutic encounter. And it's really important to keep that in mind, that if you don't think about it as a therapeutic encounter and as a collaborative effort between the patient and you or the client and you, then in my mind, we should think about whether we really want to even do that. So why should we use a brief intervention? One of the interesting things is that if you focus your, say, initial encounter with a suicidal person on getting a history, how to, what were the developmental milestones, what were past depressive episodes, what's the family dynamic, that person may walk out of that session, that encounter, feeling that somebody listened to them, but they may not walk away with any kind of way of coping, any kind of way of saying, this is really going to help me. And so if you give them something like a safety plan when they leave, it may increase the therapeutic capacity of that contact and encourage further contact. My colleague Ed Boudreau talked about doing an intervention strike while the iron is hot. In other words, while somebody is in a distressed state, it's a good time to do an intervention like this. It's kind of the same thing that we do in the emergency room when somebody comes in having had too much alcohol has overdosed, to talk about getting treatment after they are no longer intoxicated, to use that as an opportunity to increase the likelihood that they will engage in care. And then the other thing that we found is that there are some people who just don't want to be in treatment. And so they come to the emergency room for a suicide attempt, and they get the care that they want, and they, for whatever reason, we can try all that we want to try to increase their motivation, they have no interest. They can at least walk away with some sort of brief intervention that they may be able to use in the future. Okay, so our intervention was designed to reduce risk, to increase suicide-related coping, to enhance help seeking, to identify emergency contact, and to reduce access to lethal means. So one thing that's really important is that one of the rationale for doing safety planning is we have people identify the warning signs. And the reason that we do this is that when somebody is in a crisis, they may have trouble recognizing when a crisis is beginning, or even that they are in the middle of it. So you need to help them identify in advance what are their signs that a crisis is developing. So we also know that problem solving and coping skills diminish during emergency situations and during any kind of suicide crisis. And so you need a predetermined strategy. I'll talk a little bit more about that in a minute. And another characteristic that's really important is that this is done in a collaborative way. And finally, when somebody has a safety plan, if they become repeatedly suicidal and they use the plan over and over, repeated use can increase coping ability. So the safety plan was developed in the context of a psychotherapy, a couple psychotherapies, and it was eventually pulled out as its own standalone intervention. So we didn't go about developing this intervention initially as its standalone intervention. It was in the context of other interventions, and when patients mentioned that this was very valuable to them, we began to think about it as an intervention in and of itself. Okay, so this, I think, is something that is important to discuss. So one of the things that when we put together the safety plan, it was out there and being used without having an evidence base for the intervention itself. But we did put it together based on the literature of like what helped suicidal people. So we found in the literature that problem solving and coping skills, of course, helped. Enhancing social support helps, identifying emergency contact, motivational enhancement, and of course, means counseling. So here was, I would think, is the most controversial part of the safety plan, because the things that people do by themselves really rely on distraction. And so within the field, within psychology particularly, distraction, it had kind of like a dirty name. It was thought of as avoidance. And so avoidance is as a way of life is not a good thing because you never solve your problems. However, if we think about distraction as a tool in an emergency, it can be very helpful. And I found this literature that is really interesting. There are a couple studies now that show that under stress, this is using the Trier social stress test, which is a mild social stressor. People come into a room and they are given a few social stressors in front of, like it would be a group of experimenters sitting here behind the table. The person had to stand in front of them and make a speech and then do backwards arithmetic. And so it's stressful. And so when you're studying this, you look at cortisol response, the response to the stressor, and how fast somebody recovers and what their reaction is. And so this study found that distraction coping after the Trier was related to a faster decrease in the cortisol response. And similarly, another study found that people who used distraction instead of rumination, again, after the Trier social stress test, had a quicker recovery. This I find to be incredibly interesting. So it's not just that, oh, it kind of works mentally. There is a physiological process that is happening here. So in other words, it shows that in an emergency, or in a stressful situation, there are reasons behind using distraction. So the thing that I want to point out here is that although I'm talking about this brief intervention and dealing with an acute crisis, we have to think about people who are suicidal as having not just these little blips where they go into an emergency situation. There is something that elevates their risk above baseline compared to other people. And so we have to attend to that. Again, you know, what I was saying earlier about that suicide prevention wheel, we have to think about the entire person, not just helping them deal with risk. And so as a clinician, you have to deal with the depression, substance use disorder, hopelessness, persistent stressors, and so forth. And so this is the kind of risk that people have. And you notice here is weeks and months. So this is over time that elevates their risk. In contrast, this is where the safety plan comes in handy. So this is for an acute crisis where the risk kind of escalates really quickly and there is a danger of acting on suicidal feelings and urges, and then eventually the risk comes down. This, of course, is why means counseling works, because if you remove access to means or make it more difficult to have access to the means that a person would use to kill themselves, eventually the risk comes down, and it can come down pretty quickly. And so the same thing here is why we have an intervention like safety planning. We do it to help people through that kind of peak time. And you see here, this is not weeks or months, this is minutes or hours. So the risk goes up relatively quickly and comes back down. And so this is where fast-acting medications, emergency care, and brief crisis interventions can help. So, the way that I think about safety planning is there are two things. One, when we go on an airplane, we all know what to do. So for example, if you're traveling with an infant or young child and the cabin pressure drops, we all know that we put the oxygen mask on ourselves before we put it on the child, right? And so this is all pre-rehearsed. That's what a safety plan is. It's a written thing where we don't have to think about what to do. Same thing like, I don't know in Sweden if you have this, but in the United States, every October we have Fire Safety Week in our schools. And the kids all learn what to do should they catch on fire. And so I would always know in my family that it was Fire Safety Week because we lived up on a little hill, and my kids would get off the bus and I would see them rolling down the hill. And it's like, okay, it's Fire Safety Week. So they would all know to stop, drop, and roll. And so in other words, it's ingrained, it's a plan that you don't have to think about should an emergency like catching on fire occur. And so that's how we think about a safety plan. When we are in an acute suicidal state, we are not thinking about things very clearly. We're not going to be great at generating solutions. And so we have a predetermined plan. And so this is an example of the actual form that we use. And so we ask people to do it in a way that starts with within self strategies to doing to the things that are the more typical way that we think about what suicidal people should do, which is going to the emergency room, calling your doctor, and so forth. And so it takes about 45 minutes or so to do. One thing that people also have put on here is that it's a form that has been widely distributed. That's actually was not in our original intervention, but some patients really like this, and so we have kind of leave it as an optional thing, is that to talk a little bit about reasons for living at the end of the plan. So I put this up because I want to just note here, this is where the completing the plan falls in. And so there's a lot of things that happen before you actually do the plan. So first, of course, you have to assess risk. Then you obtain the crisis narrative, which I'll talk a little bit about, do a little psycho-ed about safety planning. Then you have identified from the crisis narrative with the client, identify the warning signs, then explain how to follow the steps. Then you complete the plan. So it's, although people tend to focus on this, and we do too, there are a lot of other components to the process. So what is a crisis narrative? Why do we do it? We obtain a detailed description of the suicidal crisis. So it's not a free-ranging description. It's a description where the reason that we do this is we want it really clear to us and to the patient what the warning signs are. And we don't ask them to say, what are your warning signs? We have them tell their story. And so we asked first to identify the suicidal crisis or the suicide attempt. So usually we know that. We don't ask ever, why did this happen? Why did you make the suicide attempt? Like what occurred? Instead, you engage the person kind of like they are a reporter of their own crisis. And you just have them tell the who, what, when, where, why, with not so much emphasis on the why. And so it's kind of the stance of a reporter, asking for the events, the thoughts, feelings, and behaviors without making any causal connections. So if you do dialectical behavior therapy, this is going to feel very familiar to you. It's what CBT and DBT do a lot of. And of course, as you are working with the person to do this, you maintain a validating stance. So the other thing about it that's really important is you really, as a clinician, you have to be really disciplined. You know, if you think about, you have 45 minutes, 50 minutes to do this, you stay on track. If the person kind of veers off and starts talking about their family dynamics, or that's, you kind of pull them back, or it's something that happened in their remote past, and you refocus them on the narrative that led up to this event in a kind of a narrow way, because you want warning signs. What happened in the past, the family dynamics, except if it's a particular warning sign, are to be dealt with elsewhere. You have a task in front of you and you stay really task focused. So this is just an example. I won't go through the whole thing, but it shows you just how you go through all of this and you'll see here that some are behaviors, some are thoughts, and some are feelings. So binge eating, feeling empty, being agitated. This is a thought, afraid, an emotion that my boyfriend will leave me, feeling hopeless. So you can see there are a whole bunch of things that led up to this person's overdose. Now, the way that we do this is we present this to our patients as a suicide risk curve. This is what we call the suicide risk curve. So it's that curve that I had that shows where people are in danger of acting. And so this is an example from one of my colleagues' patients. So the supervisor was critical at work. The person thought everything is falling apart. He began to drink. He went home. He had an argument with his wife. And he said to himself, I can't take it anymore. I'm helpless. And then had the thought, maybe it would be easier if I ended it. He happened to have a gun in his home. He got out the gun. At the same time, his friend called and interrupted him, told his friend what was going on, and his friend took him to the emergency department. So you could see that these are the things. And where did this come from? It isn't like I just asked the person, or my colleague just asked the person, what are your warning signs? This came from their story. And so these elements of this would end up on the person's safety plan. So having the thought, I can't take it anymore, having the thought it might be easier to end it, maybe drinking a lot, or drinking in the context of feeling that everything is falling apart. And so this is this person's warning signs. And so this is an overview of the safety plan. I'm not going to go into this in detail here. I want to talk a little bit about our results, but this is basically, you help them recognize their warning signs, you use internal coping strategies, help them socialize with others as a way of distraction. You help them identify who would be there to support them, who they could reveal the crisis for. Again, socializing with others as a way of distraction. You do not reveal that you're feeling suicidal, so you use people in two different ways. Contact mental health professionals and agencies. And then finally, at the end, we talk with them about reducing access to means. Now, we talk about this at the end, even though this is not like an actual step of like they do 1, 2, 3, 4, 5, 6. This is what they do when they leave the office. They do what they need to do to cleanse the environment and enlist people to help them. But we put it at the end of this to kind of show them that there are things that they can do instead of having their means available to them. I worked a lot with patients with borderline personality disorder, and they like to keep their means available to them as almost like their security blanket. And so I try to show them that there's other security blankets that we can have here, and so that they might more likely consider reducing means. And then finally, of course, the reasons for living. So the thing that's really important in doing this process, and I can't stress this enough, is that the individual who is suicidal is a partner to you, and that psychoed is crucial. So you don't just say to the person, oh, I see you made a suicide attempt, let's do a safety plan. You explain how suicidal crises come and go, describe the suicide risk curve to them, explain how the safety plan helps them prevent acting on suicidal feelings, explain when it should be used, explain how using the strategy will enhance their sense of self-efficacy, which is what patients have said to us, and a sense of self-control. And so this is all, I say this to you because this is not in the written document about the safety plan. This is the kind of the psychoed that we do prior to doing the safety plan. This is an example of somebody's completed safety plan. And the thing that I want to point out here is that it's pretty specific and it's pretty individual. So this is not anything that are necessarily like typical warning signs. So thinking I have nothing to live for, sleeping more during my day, when I get really depressed, that's a kind of a typical warning sign, but this can be really particular. And then here, the kind of things about the internal coping strategies, looking at pictures of my son. Now, this is nothing that we would normally think of as something that is distracting. Watch a game on TV, play baseball, like that's baseball or football, or go lift weights at the gym. This actually probably would be more down here. So, but the reason I put this up is it's very, very specific. And in the United States, this intervention has taken hold that there is an accrediting agency called the Joint Commission, and they have recently recognized that this is kind of a part of what should be done for an acutely suicidal person. Okay, so does it help? So this is the article that appeared in JAMA Psychiatry last summer, where we looked at safety planning with follow-up compared to usual care in suicidal patients who were in the VA. So the thing I want to emphasize here is that this is with follow-up. And so, so this is not just safety planning alone. This is safety planning with telephone follow-up. And so what we did in this study was we administered safety plans in the emergency department for people who were experiencing a suicidal crisis but did not require hospitalization. So this is like the moderate risk patient. So these were not the high risk individuals. The high risk patients were hospitalized. And then we did structured follow-up phone calls. And so we had 5 EDs that received the intervention, and we matched 4 of them. And then we looked at suicide behavior reports and use of services. So we had almost 1,200 veterans who received the safety plan. People didn't have to do this. We approached them and asked them if they would be willing to do a safety plan. Virtually everybody said they would. And these were people that were in the emergency room. People often like to just get out of the emergency room as soon as they can, but they were willing to do the intervention with us. And then we did follow-up phone calls with them until they were engaged in services. We had about almost 90% who we were able to get follow-up calls with. On average, we did 3.7 calls, so about between 3 and 4 calls. You can see that every now and then somebody made, one of the clinicians made a lot of calls to somebody, but we were mostly in this range of the number of calls. So we stopped calling when somebody got seated in service. or they said they didn't need calls anymore, that they were no longer suicidal, or they didn't want to have contact with us. The mean number of attempted calls, but we couldn't contact them, so 3.4. The mean number of days between the first and last completed call was a little over a month. So you can see this is that, I'm sure this is the same person the clinician who did 26 calls and reached out to almost a year. But by far, this was about the length of time that we did follow-up phone calls. So it was a very brief period of time. So does it work? So again, remembering that this is safety planning plus telephone follow-up, which we called SPI plus. We reduced the number of suicide behavior reports by almost about half. So 45% fewer suicidal behaviors over a 6-month period of time. In addition, we found that the people who were in our intervention were more likely to actually go into treatment. And so this is really important. And it was mostly in terms of, we did substance abuse treatment and mental health treatment, and it was more likely that they went to mental health treatment. So the thing that we also did here is we looked for mediation. So we wanted to see if being in treatment was the thing that caused the lower suicidal behavior. So we looked at the effect of treatment engagement on as mediating the relationship between the intervention and the outcome. And in fact, it was not mediating. It was the actual intervention. Of course, we can't tell which part of the intervention, or was the intervention in combination. So was it safety planning that was the most active ingredient? Was it the follow-up phone calls that was the most active ingredient, or was it the combination? All we can say is that the combination seemed to decrease suicidal behavior and increase treatment engagement. So this is just examples of other kinds of things that are ongoing, and I'll give you just a few examples of this. So these are mostly things that were not done in our group. This group at our sister hospital looked at the impact of safety plans in an outpatient clinic, and this is a relatively small sample. But what they found was that for people who were suicidal, outpatient appointments increased, ED visit, inpatient days, and suicide attempts decreased just for people who got the safety plan. In this one, people did an intervention doing safety planning in primary care. And again, we're not talking about a large sample here, so the data is just kind of like beginning to percolate outside our group. And so they found that safety planning reduced suicidal ideation in primary care, which is actually a really important place to think about for doing an intervention. In the United States, we're really working very hard to integrate behavioral health care within primary care. And so this is really important. And this was an interesting study looking at suicide attempts in refugees. And so they had a camp where they did this intervention, and then a camp where they didn't. And it was kind of layman contact plus safety planning cards in the intervention group. And they found that suicide attempts in refugees with the safety plan and increased contact were reduced. And then I am involved in this other study along with my co-developer, Greg Brown, with a group from Michigan State and Brown, where they are doing a trial of the exact same intervention that we did in the VA, where they do safety planning in the jail while the person is in the jail, and then they do follow-up phone calls. And so these data are just beginning to accrue. I think it's a really important population to address. They had to recruit 800 people over about 3 years and in 2 sites, and I thought they would never meet their goal. They met their goal really quickly, and they had to be acutely suicidal individuals. Okay, and so then we have a couple of other kinds of studies that are kind of like spin-offs. So my colleague, Marianne Goodman at the Bronx VA has taken safety planning and gone in the opposite direction. Safety planning is a brief intervention, and she's kind of taken safety planning and exploded it out into a group intervention. She's written a very interesting manual. And so she took the steps of the safety plan and she's identified what are the skills that go along with them. And so far she just has a feasibility and acceptability study, which shows that it is feasible, that the veterans really like it and find it helpful. And now she's doing an RCT. We have developed in our group an inpatient treatment that is a 4-session group inpatient treatment, which includes safety planning. And so these are the 4 sessions. So we have like a reducing vulnerability session, a psycho-ed session, safety planning, and then a hope kit. I did this because in the United States, when you go into an inpatient unit, you get nothing that is really suicide specific in terms of any group treatment. There might be like process groups that are in general, or more likely it's art therapy kind of groups, or coping in general. And about 50% of our inpatient hospitalizations are for suicide-related concerns. And so it only seems right that people should not leave the hospital without a safety plan. And so we have developed this 4-session group treatment that people can come in and out at any point in time. And so far, the only data we have is that suicidal ideation goes down over time and that it's feasible and acceptable. We're doing a large-scale implementation of which safety planning is one piece of it, looking at zero suicide. I'm happy to discuss this later. But what we found is that what I want to point out here is that, in fact, we do get people who will, clinicians who will do safety plans with their clients. So from having introduced it to 6 months later, about 2,500 safety plans were done in outpatient clinics. So it went from a very small number to a tremendous increase. So with Ed Boudreau, we've developed a computer-assisted safety plan for individuals at risk. And so all we have so far is usability testing and feasibility and acceptability. This is done to help clinicians kind of walk through the safety plan with the patient. This is not done, this is not designed for the patient alone. And then Eva Tsa did a study with Cheryl King on motivational interviewing along with safety planning in adolescents, and found that safety planning with motivational enhancement, motivational interviewing, increased the likelihood that that the safety plan would be used. And this is a study looking at disseminating safety planning in college counseling centers. Again, we don't have a lot of data yet that that shows that that it actually has an impact on suicidal behavior, other than our initial study. But one of the things that I want to point out is that quality matters. And this is actually really, really important. And so we have developed fidelity measures, measures of the quality of the intervention from both the listening to audio recordings or watching the interview being done, or just rating the form itself. And so it's really important to think about it as more than a piece of paper. It's a tailored individual intervention. So why do we know quality matters? Gamara did a chart review and found that that safety plans were of moderate quality and that they had no explicit evidence of ongoing utilization in his study, but an additional safety plan study found that quality was low, but that higher safety plan quality scores decreased the likelihood of future suicidal behaviors. And that individuals indicated that plans were most helpful when they developed as a partnership. So this is the collaborative part of it. So there's some idea that quality matters in this. This is our simple app that people can use on their own. It's, and then I thought I would just end by just talking about, you know, what our patients tell us. And so it's one thing to show data and impact on yes, it has 45% fewer suicidal behaviors. But to me, there's nothing that, that speaks as loudly as listening to our patients talk about the intervention. And so we did a qualitative study to ask about, did people use it? What did they think about it? And here are some of the comments. It gave me the opportunity to more clearly define signs when my mood is beginning to deteriorate and when to start taking steps to prevent it from further worsening. That's exactly what we would like to see. I was having problems with suicidal thoughts. This was a way to help me deal with the crisis and not let it overwhelm me. Getting a safety plan, I was in such distress when I got here, this saved my life. And this idea that this saved my life, I can't tell you the number of times we have heard this from patients over and over and over. I think this is something they should always have and keep. It's something they should get for others in my situation. I would definitely recommend doing safety planning. I would tell them that it saved my life. How has it helped me? It saved my life more than once. And I put this up here a couple times because this is what we hear over and over. So I will end by just, this is my contact information. We have a website where you can download our forms if you want it, and thank you so much.